Welcome to the Therapist Thrival Guide. My name is Miranda. I'm a licensed clinical social worker, and I'm here with Dr. Sara Polley.
Hi.
Do you want to introduce yourself?
Sure. So I'm Dr. Sara Polley. I am a psychiatrist by training. So I have a child adolescent psychiatry certification, adult psychiatry, and then also addiction medicine. So my jam is kind of specializing in young people that have struggles with both mental health and substance use disorders. And here at Ellie, I'm the chief medical officer and also have a pretty active outpatient practice where I see people of all ages, really.
You do it all. I mean, truly, you do it all. We're like slotted to do these podcasts in between right before you go see other clients, which is just super cool to me. I love that. And today we are going to talk about addiction because I think this is a topic we haven't spoken on really at all yet in this podcast. And I've had a lot of interest in people who have wanted to learn more about addiction medicine and even just, like how do we support clients who are struggling with addiction? Because before we started recording, I kind of made a comment that was like, I don't want therapists to think that they can listen to this episode and then like go right ahead and start treating addiction. But I do hope that they'll listen to this episode and be like, oh, like now I know when to refer out, or even like I know some different medications that might be helpful, or questions I could ask a client that might be struggling, or, where is the line of, maybe your casual drinking it turns into more of an addiction or something like that. So I think this is going to be a good conversation. I'm excited to have you on here.
Yeah.
How did you get started in all of this? Like what led you to kind of this specialization?
Yeah, it was kind of a journey of a few different things. And I think it didn't really come together in my mind until I was almost, I think, done with training as to like what led me to where I was.
Which, by the way, I learned recently that you have, like, going through your training as a psychiatrist, you have caught babies.
Yeah, so that's
which is
thing.
So cool.
Yeah, no, I know. That's one thing people don't always know is that psychiatrists are medical doctors, and so we do the same rotations that any doctor would do when they're in school. So I got to catch babies. I got to feel someone's lung one time during a surgery. Yeah, it's
so cool.
Super privilege. I mean, it was really cool to be able to do all those things and then decide I wanted to do something more specialized regarding the brain and relationships and that kind of thing.
Absolutely amazing. Okay, sorry, I interrupted you. Go back to your story. How did you get here?
Yeah, so I was a kid where I had the idea that I was going to be a doctor ever since I was little. And then I honestly, I've realized now I think it's my personality style that I'm the kind of person where I don't like ambivalence. I don't like to not know. So if I think something's good, I'll just choose that and then do it. Which in this case, I kind of always had that in my mind. So when I went to college, that was what I wanted to do was go to medical school. And thankfully, I would take the classes and they seemed to go okay for me. So then I would continue to take the classes until I was, applying for medical school. And then went to University of Minnesota for my medical school training. As this was happening with my academic career, my family was kind of struggling a bit. So I had my dad struggled with alcohol use disorder for a lot of my early childhood. And then he was okay for a bit. And then I actually had a brother that passed away. And then after that, he struggled again with alcohol. And so ended up passing away secondary to the illness when I was in college. Yeah. And so it's kind of interesting because psychologically, I think in my head, those were sort of two separate things. And I was very ashamed about my experience as a child of somebody that struggled. I didn't want people to know that. In fact, I would tell people that he passed away from something else because I was worried about telling them the truth about what happened. So that was kind of hanging out there. And then I was doing my medical school stuff and then started to do psychiatry or be exposed to psychiatry in medical school. And I did a rotation actually at the Betty Ford Center in California. That's part of Hazelden. And that was the first time I had really thought about, in addition to my medical stuff, I also have a dad that struggled. And I also have the experience as a child of somebody with addiction. And so that was kind of the beginning of starting to think maybe these are things that could be incorporated and I don't have to keep this other part of my life in a box, that maybe I can, have that be part of what my motivation is for what I do for work. And so that was really, and then of course, through a lot of my own individual therapy, I was able to kind of reconcile a lot of the trauma that, you experience as the kid of somebody that struggles, which I think made it possible for me to be able to move my experience into more of a purpose rather than have it necessarily impact my day-to-day interactions with patients. But yeah, so then I kind of became more interested in, okay, maybe I want to do substance use disorders within psychiatry, particularly prevention of the development of substance use disorders is a huge interest of mine because I found it really shocking, actually, when I first learned that addiction is a pediatric onset illness. Because, yeah, right, it's shocking because you don't think of that. You think of, a 50-year-old who's struggled with addiction. But if you look at how they came to that place, it started when they were a young person. It started with difficulty with coping. It started with, exposure to ACEs or childhood adversity. And then exposure to substances as a young person is what kind of primes the brain then for the development of adult addiction. Sure. So then I thought, well, wouldn't that be cool if I could do child-adolescent psychiatry and then I could really interact with kids and families before they're 50 and struggling with a chronic disease. I could really try to prevent the onset of the chronic disease. And so so then when I started to do my residency and fellowship, at that time we had to travel to do interviews. Nowadays, I talk with med students and they do everything virtually, which is kind of nice. But at the time we had to travel. So I took out a private loan with like a horrible interest rate because I was like, I want to find a program where I can get training in pediatric addiction. Amazing. And it was actually very hard to find. Not only just adult programs that exposed me to adult addiction treatment, but also specifically pediatric, like child-adolescent programs that exposed me to addiction. I remember I had an interview out like at one of the West Coast places, and I said, like, I really want to be trained in addiction, pediatric addiction. And they looked at me and they were like, well, we don't have anybody here that would help you with that. So, but thankfully I found both an adult program and a child program that had faculty that were specializing in that and did research in that. So that was a huge integral part to how I ended up where I am because it was thanks to mentors that really taught me how to approach patients that have co-occurring illness, help to become familiar with it so it wasn't a scary thing. It wasn't like that patient shows up in your office and you're like, oh my God, I don't know what I'm going to do with this. This is really complicated. So start to develop some efficacy or like ability to help patients that have kind of complex struggles. So that's the long version.
Oh my gosh. No, this is fascinating. I feel like I'm learning so much about you. How do you prevent this? I guess I'm just thinking through like when a kid is coming to a therapy office, like there's an identified issue, or if a kid is coming to see a psychiatrist, do you feel like you're still able to prevent it at that point? Or what does prevention look like? Like parents lock up your alcohol or like, I'm just so curious about this.
Yeah. Well, so the idea behind prevention is that it can start even before the child is born, which is kind of crazy to think about, right? But to help a parent or somebody who's planning to become a parent think about their own relationship with substances, particularly alcohol. And in our culture, alcohol is extremely normative. I mean, if you look at statistics, it's like 85 to 90% of people will drink alcohol at some point in their life. So it's virtually something that all of us do.
Yeah.
But to help them to think about what their relationship with alcohol is and how they want alcohol to fit into their picture of their family values or their family activities. And so there was a research study that was done where they asked little kids about alcohol. And this was, kids that were, just verbal, like 4 years old. And their parents had never explicitly talked to them about it, but said, what is alcohol? What does alcohol mean? Yeah. And kids are already developing ideas about what substances are. One of the kids said something like, well, alcohol is for parties to have fun, right? So they're already making that connection that to have fun or when you have people over, then you have alcohol. And so but trying to be cognizant that your behavior as a parent is going to impact how your child views the world. And that can happen again, even before you start having children, but then as they're growing up, what just your own family patterns, your own behavior and what you're exposing your child to. So I think that's a part of it. I think another part of it is, so there's, I think, education, and then there's also helping kids with coping. That's a big thing that you see happen is that it's almost like kids that are at risk for addiction have hits from many different areas, meaning like they often have a genetic predisposition because they have a parent or family history of substance use disorder. If that is the case, sometimes they have a chaotic home environment. Sometimes they're facing systemic adversity that's no fault of their own. And then they end up getting multiple kind of risk factors. And a lot of kids end up starting substance use because either they're feeling lonely and isolated and they're just looking for a community or a group to belong to. And then that's a community that they come upon that normalizes substance use, but not only that, accepts them and hangs out with them, right? And then they have good experiences and they feel like they have a community. So how do you help kids make pro-social connections in spaces where substance use is not happening and prevent them from feeling lonely and isolated? So sometimes that's social skills training for kids that might have struggles with that. Kids with big feelings, right? Sometimes you're overwhelmed. You don't know what to do. You've tried some things that maybe you've thought of. You might not have great models at home of what to do when you're feeling overwhelmed. And then you stumble upon a substance and you go, oh my God, this works really well, right? Like I smoke marijuana
I feel great.
I don't have thoughts about cutting anymore, you know? And so intervening with kids to help them even preemptively before they've ever even thought about using a substance to feel confident in being able to cope with big feelings and also normalizing, it's okay to be somebody that has big feelings. And how do we manage those in ways that, aren't going to end up causing us more harm in the future? So it's just kind of a brain dump of what came to me.
No, that's amazing. I'm curious, how has your world changed a little bit within addiction with like some of the laws changing around marijuana use, recreational marijuana use, or even just alcohol is legal, just like how are you looking at addiction differently or are you even?
Yeah. Well, I think, the two things that have kind of always been constants that I think there's been increased awareness about are nicotine and alcohol. Right? Those two substances, for better or worse, have kind of been a part of our culture for a long time. And a lot of people don't really bat an eyelash.
Right.
We have discussions sometimes because there's definitely a stigma about marijuana use still in our culture. And I think that will change as more and more states legalize and potentially on a federal level, marijuana is legal. So clinicians get really worried or antsy around marijuana. Like someone says, I'm using marijuana and they get really and even prescribers go, well, maybe I should not prescribe medication because it might interact with the marijuana.
Yeah.
But then you ask them, well, would you say the same thing if a patient told you they drank alcohol? And you go, well, no. Or would you say the same thing if they told you they used tobacco cigarettes? And you would say, well, no, I would treat their mental health, and I'd work with them on their use, but like it wouldn't prevent me from treating, so it's like we're all very familiar with nicotine and with nicotine, tobacco, and alcohol. And then I think as we move forward as a culture, there's going to be a lot more normalization of marijuana. There already has been, but I think even more. And so I think it's going to, in our culture, probably become similar eventually to how we think about alcohol, where it's like probably normal that people are going to try it in their lifetime at some point, and that there'll be a certain subset of people with risk factors that end up going on to develop a use disorder or an addiction, but that there will be people that just use it recreationally. And so how do we find that subset of individuals who are at risk of development of an addiction to it and help them with education preemptively so that they can understand that maybe my relationship with marijuana or whatever the substance is has to be a little bit different than my friends, because I have these risk factors that I may go on to develop an addiction because I'm exposing myself to the substance.
Yeah. I mean, that leads us really into kind of one of the other conversations that I'm hoping we can have is like, at what point does it cross the line into a substance use disorder? Because I mean, I see mostly college students at this point as a therapist, and a lot of them use alcohol, a lot of them use marijuana. And I mean, like they might answer perfectly on the cage aid. They might say, oh no, I don't think about alcohol as soon as I wake up, but you also, I mean, it's just tricky because you're like, okay, well, you're smoking marijuana every night, or you are going and drinking to the point of blacking out this much, like insert a number of times per month or something. And so, I mean, I think that we can talk about coping skills. We can have some of these things, but I think as a therapist, sometimes I'm like, ooh, is this out of my like comfort zone? Like, should I be referring this to something more? At what point does it kind of cross into more of an addiction?
Yeah, that's a really good question and topic for us. Because one thing that I've learned, not only from my own experience, but just from talking with therapist colleagues, is that education about substance use and addiction is completely lacking in training, which is so heartbreaking, right? Because if you think about it affects, 1 in 10 people have a substance use disorder. So it's sort of like, and even more than that, have struggles at times with substances, but maybe don't meet criteria for a disorder. And so, and the population that we work with, people that have mental health struggles, are at even an increased risk of having substance use. So, my hope would be kind of at baseline that there can be work done with incorporating more education into training for therapists and for psychiatrists and really everybody.
Sarah, I don't know if I didn't take a single class on addiction in my grad program, like not a single one.
Yeah.
Because I think that I had this idea of like, this is the population I'm going to be working with. And at the time it was more of like child welfare, adoption, foster care, kids. And I mean, we talk to therapists all the time where it's like they go into it thinking they're going to be doing this and then it shifts. And I mean, I didn't take any classes around addiction or anything like this because I was thinking, I'll just work with kids, which I mean, you've kind of already like debunked that a little bit. But no, I feel completely unprepared to work with some people that are struggling with this.
Yeah. So I think one thing I would encourage for anybody that's working in the mental health field is to just like look at the DSM and look at the criteria that are listed for substance use disorders. Because what you'll see is that they have different categories for different types of substances, but the criteria are really the same. There's 11 criteria. And the way that you have a disorder, or the way that you meet criteria for a diagnosis is by having a minimum of 2 of the 11 criteria puts you into kind of a mild.
That is not very many.
Right, yeah.
Wow.
A mild use disorder category. And just because someone might meet criteria for a use disorder doesn't mean, oh man, now they have to go to rehab or, something bad is going to happen. Or it doesn't even necessarily mean, oh, this is out of my scope, right?
Sure.
But part of it is just having that discussion with your patient. And I think what I like to do is empower clinicians to say, like, if you're a therapist or you're working in mental health, like the DSM is your realm. Like you have the right to use the DSM and understand the DSM and communicate about it with your patient. And so, I've had discussions with patients where I've literally pulled my DSM out, right? And I've pulled up, marijuana use disorder, for example, and we go through the criteria and I say like, and sometimes the individual has trouble identifying for themselves, well, no, I haven't had any negative consequences from my use. And then I'll say, oh, well, like, I don't know, but remember when you told me that one time where like you ended up having to like bail on your car because you thought the cops were following you because you were paranoid. And yeah, you're right, the cops didn't come get you, but then you were like outside for a couple hours and you had to have somebody come get you. Like that's kind of a negative consequence. And usually they'll say, yeah,
doesn't seem positive.
Yeah, right. They'll be like, yeah, okay. So that's one piece, I think, is to just familiarize yourself with what the criteria are. And that's also a way to help you think about how to talk to your patient about their use. And so if your patient says, yeah, I smoke marijuana every night, it helps me sleep, it helps me with my anxiety, right? You can then, if you can think of some of what those criteria are, you can just weave them into the conversation. It doesn't have to be formal. You can say, oh, well, okay, has there ever been any, like, is there any downsides to doing that? Right? Like asking open-ended questions so that the patient can then fill you in on maybe they would meet criteria. So that's a kind of a way that I approach it, is to ask in that way. And I think one of the other things that clinicians can do in the office, and I think we're going to have a topic about this later, is about motivational interviewing. But there's a lot of patients, I think, that you'll see that will talk about how they're using substances and they don't really see it as being a problem. And so I think there's a tendency as helpers that we want to like convince the person that there is a problem, especially if we see facts and data that suggest that there is a problem. And then we want to get them to go get help. Like we want to say, well, you need to go do a substance assessment, or you need to go get more help because this seems like a problem and I don't know what's going on. And so I think it's okay if you want to move a little more slowly than that, especially if you have a patient that isn't ready to go get an assessment or doesn't feel like there's an issue, to just spend some more time exploring with that patient. And if they bring up downsides or things that they've noticed that are not desirable from their use, then just spend some time highlighting that and talking about that as a way to move them towards being interested or willing to go do maybe a further assessment if that's what you think would be helpful for them, or if you feel like you do think that there's a use disorder and that it's causing issues for them, but they're not, you got to get them willing to kind of go and seek more help.
When we talk about substance use disorder assessments, my mind immediately goes to like when I worked in child protection and we'd be like, go do I don't remember what it was called.
Rule 25.
Yes, yeah. No, go do a Rule 25. Bring your results back to the court and then we'll get you into inpatient or we'll get you into residential, And so I think that I equate like substance use treatment or substance use assessments as like a let's get you into like a super high level of care. But are those something that you would have a client do even if they were just wanting to do like a lower level of care? Are there what are the lower levels of care when it comes to substance abuse treatment?
Yeah. Well, I'll preface by saying that, so the whole, I won't go too historical, but like the whole field of substance and addiction treatment kind of developed outside of primary mental health and medical services, partially, all because it was shunned by mental health and medical. Like the
It's
whole
completely separate. It's
Right.
like, go deal with that. Then you can come back and get.
This is a social moral issue. You need to like get yourself figured out and stop it. And then you come back to us here in our like gentrified mental health and medical setting, and then we will help you, right? And so as a result of that, like community-based organizations grew in order to take care of people. And a lot of them started out of churches or out of social services organizations. And that's kind of where we get the, community-based like 12-step programming, was really like peers helping peers to help individuals who had otherwise been shunned from help from all other venues. And so kind of like moving us now into today's time, kind of what, as a result of that, we still have a lot of silos between treatment. And so this idea of the Rule 25 assessment or the substance use assessment, became a thing because there needed to be a way to ensure that these organizations who sort of existed outside of the rules of healthcare were actually providing evidence-based care, they weren't just sort of accepting people into rehab that didn't actually need to be in rehab in order to make money. So that's sort of the idea behind this assessment, is that we want to get a thorough history and picture of what's happening, particularly because withdrawal and intoxication can be dangerous. And then we want to make sure that you're going somewhere that has the capability to actually help you and isn't going to take advantage of you. And so that's kind of the purpose of the assessment. And their question about the different, no, when you do an assessment, it's not like you have to go to rehab or inpatient. I think what happens, right, a lot is that there's such a stigma to seeking care and people don't go get an assessment. So by the time they finally are assessed, their illness is very severe. It would be like if you waited to show up in the ER until you were actually having a heart attack, then everybody would get admitted into the ICU, right? But so the goal being that we want to actually encourage people to go get assessments at lower stages of the illness. Because the way the assessment's really structured. That's part of like when licensed alcohol drug counselors do their training, that's a big part of what their training is in how do you do this detailed assessment. It's double-edged, right? Because on the one hand, that's good that we have people who are highly trained to do these really thorough assessments. And on the other hand, it creates a barrier sometimes where you refer to this like nebulous assessment and then you hope that there's a person that can do the assessment and then you wait for the results, right? Versus it being something that's easily accessible to any of us, where we could just assess and then make a recommendation right in our own offices. And my hope would be that in the future that would be something that would be possible, is that all of us as mental health clinicians would be trained, but that's kind of not where we're at now. But anyway, go for the assessment, get the detailed information, and then at the end, there's actually a really pretty detailed rubric to help that individual that did the assessment determine what the appropriate level of care is based on different dimensions. And so they'll say the ASAM dimensions. And ASAM is the American Society of Addiction Medicine, which is the group that houses these assessment like questions and then the criteria and renews them and refreshes them, kind of like they do with the DSM. And so at the end, it'll be a rubric, and then it'll determine, are you appropriate for just outpatient support, meaning an outpatient dually licensed therapist? Do you need a medication management provider for addiction? Do you need an intensive outpatient program? Do you need a day program? Do you need to go to the hospital because you're really seriously ill? Or do you need to go to a detox? Do you need to go to a residential? So there's that kind of lists, like in a down and dirty way, like the different spectrum of care. But yes, there are lots of different types of care people can receive. It used to be, and the reason they called it the Rule 25 was because in order to get funding to go to a program, if you had medical assistance, you had to have this Rule 25 assessment in order to use your funding from the county or the state. They've actually done away with that because they did find that created a barrier for people. So at this point, you don't have to actually go get a Rule 25 in Minnesota. You just have to get a substance use assessment, and that uses the criteria. So that's made it a little bit easier. But yeah, partly as a primary mental health clinician, having maybe even just a little familiarity with the different levels of care so that you can reassure patients. Because I have a lot of particularly like adolescent patients and their parents, the adolescents like, I'm not going to rehab. And the parents are like, I don't want to pull my kid from school.
Yeah.
And so I try to be very reassuring. And I'm like, you know what? It's not necessarily that you're going to be suggested to go to an inpatient program. And even if you are, you have the choice to determine what you want to do for your care.
Sure.
So if that's not a good fit for your family, the criteria are actually updated and designed specifically to have incorporation of the wishes of the family and the child, so that, and if it is a child, so that it's not like you're forced to do something.
Can you ever be forced to go? Like, is that something that, I don't know, like, you know how you can be committed?
Yeah.
Is that something that you could be forced to go to rehab? I'm thinking of Amy Winehouse, but.
Yeah, that's actually a pretty controversial topic. So if you think about kids, parents can sign their children into treatment.
Yeah.
But it's interesting. It's an interesting balance because the treatment programs are often considered voluntary.
Yeah.
Meaning that they're not like a hospital where they're locked and you can pound on the door as much as you want, but you can't get out, right?
Right.
And so that becomes a little tricky when you have teens because the parents we often will help coach parents to compel their child to voluntarily stay in treatment, even if it's not really voluntary and they don't really want to, by being a parent and having certain expectations and saying like, look, like if you think you're going to come home and I'm going to pay for your college and you're going to have the car and you're going to have a job, then you need to do this because we're not going to be doing that unless you complete the treatment program. So that's one piece. And then with adults, it really varies by state. So I've practiced in, Minnesota, Maryland, and Massachusetts. And Minnesota is one of the most hands-on when it comes to like forcing adults to do things with their mental health and with their substance use. Yeah, like
for better or worse.
Yeah, for better or worse, right? Like Minnesota is one of the very last states that has what's called outpatient commitment, where not only can you be committed to have to stay in the hospital, but then even when they discharge you from the hospital because you're better, you can be on almost like a probation where you have to take your medicine and you have to go to your treatment in order to stay in the community, which that like other states don't have that. It's like once you are better and your mind, a lot of times this is for patients that have severe psychosis, right? But once their minds are clear and they're functioning, they can go and be autonomous and make their own choices. But Minnesota's like, well, yes, but you also have to do these things in order to fulfill the stipulations of your outpatient commitment. And these can last for years. Like they can get renewed.
Wow.
Yeah. So anyway, but particularly for substance use, yes, in Minnesota, someone can be committed or put on a hold because of the severity of their substance use disorder, that they're at risk to themselves or others because of the substance use. But again, a lot of states don't have that, but we do in Minnesota.
Interesting. So when we talk about like going to treatment or having different treatments in general, what are some evidence-based treatments or like modalities, or like, I'm just thinking of someone who might be interested in learning more or doing more specialized addiction counseling. Do they have to be an LADC? Do you know that?
No, so you don't have to be an LADC to do addiction counseling. Really, I think if a primary clinician or a mental health clinician wanted to do things with substances, I would encourage people to educate themselves about the impacts of the different substances on the brain, what intoxication withdrawal look like, about, what the risk factors are for development of addiction. But yeah, the good news is that most of really the therapy techniques that we already use for primary mental health issues have an evidence base for use in substance use disorders. So the kind of one, and it's not a complete exception, but what's called 12-step facilitation, which is, the model of AA and NA, where an individual works through the steps. And when we say 12-step facilitation, we're referring to a trained clinician being part of that process versus just the 12 steps, which is like when you just go to the community support groups and do it with a sponsor or do it on your own.
Sure.
Kind of to back up just a little bit, an overarching theme of all of the kinds of treatments that work for substance use, which I think is probably the same for mental health, is to work on the loneliness and isolation that happen. And so when they do research studies about really like any different kind of modality of treatment for substance use disorders, a component that seems very integral is a sense of connection with others and a resolution or an improvement in the sense of loneliness and isolation that happen. And so, like, for example, the 12-step programs, one of the big reasons why those are effective and those work, isn't, and people in recovery very much love the 12 steps. So this is very controversial of me to say, but is more actually about the community and the sense of connection than it is about the actual details of the 12 steps. I think those are a good add-on for some people, not everybody. But it's this idea that you've joined this community of people that love you and understand you and will be with you even when you struggle and are there for you. And then there's community activities and different things and a group that you can hang out with that's making pro-social choices, isn't using. So, but even when it comes to cognitive behavioral therapy is very indicated for treatment of substance use. There's a lot of really great free resources. If you go to smartrecovery.org, which is just SMART recovery.org, that will, if you're a clinician and you look at the worksheets, they're basically just CBT worksheets, but they're especially phrased to be addressing, thoughts about substances or triggers or different words that are more classic to the addiction field. But you'll look at them and go, oh, I know what this is. This is just the CBT triangle, or this is just a thought record, So CBT, very evidence-based. Acceptance commitment therapy is also very evidence-based. Yeah, DBT is again another one that has evidence, particularly with co-occurring trauma and substance use, which most of my patients with substance use have co-occurring trauma. And then there's motivational interviewing, which we'll talk more about, but just as kind of a quick overview, that one's not considered necessarily a therapy. It's considered a therapeutic style. And so the great part about it is that you could be, let's say you're pretty effective and trained in cognitive behavioral therapy. You can sprinkle motivational interviewing into your work, no matter what kind of your particular training and your modality is your preferred modality.
I did a motivational interviewing class in grad school, and it was like through the public health department or whatever at the University of Minnesota. And I was the only clinician. I took it with all veterinarians and nutritionists and like just people that were in med school. And it was so interesting because I feel like I then that was early on in grad school. And then towards the end, I was like, motivational interviewing is not just for clinicians. Like it's for everybody.
It's for your marriage. And for your children.
For your children, exactly. And our next episode is going to be on motivational interviewing. So stay tuned. But let's back up for a second, because you talked about kind of the co-occurring disorders of trauma and substance use disorder. And I want to just kind of like touch on that a little bit, because even I think that previously there was this idea of like, you go deal with your substance use and then you can come back and seek therapy, or you can then deal with your trauma. We know now that that's not necessarily the way that you should be doing things. But I want to kind of dive into some of that a little bit more, and curious on like, what is the right way to be going about that? Should you really just be doing like therapy throughout treatment? That's such a silly question, right? But let's just talk on that for a second.
Yeah. So yes, the answer is yes. No, you should treat both at the same time. I always love to use like medical analogies, because I just feel like they put in such stark contrast, like how we have this kind of unconscious bias that impacts the way we think about substances, So like if you had a patient that presented, and I know this is primarily for therapists, but this example probably is going to be obvious, right? So if somebody comes to the doctor and they have high blood pressure and obesity, right? We don't go like, well, your high blood pressure will probably get better if you aren't obese. So why don't you go and not be obese and then go get help with that, and then come back and then I'll give you a treatment for your blood pressure. It's like, well, no, because damage is going to happen from the blood pressure being high. And of course, and then you're also not going to do the reverse, so it's like, we got to help people with all of the things that they're presenting with. And so yes, if someone has, let's say, and this is actually a hot topic when it comes to ADHD and treatment of ADHD from like a psychiatric medication perspective, is if somebody's got, PTSD, ADHD, and cannabis use disorder, we're going to try to create a plan for them that incorporates treatment of all of those things at the same time. Because someone's going to do better with their cannabis use if we're helping their PTSD. They're going to do better with their PTSD and their cannabis use if we treat their ADHD. So the idea that these things are separate is just like dumb.
Yeah. No, they're so interconnected. Absolutely. So then when you're working with like, let's say you're working with a teenager who is struggling with cannabis use, and the parents are like dragging them to these appointments and being like, he needs to stop. But, like, I'm just like picturing the typical vignette or something. But if the teenager doesn't want to change, what do you do?
Yeah. Yeah. Well, yeah. And that actually brings up another type of therapy. That was a great lead into one that I didn't mention that's evidence-based for substance use, which is kind of unique, which is called contingency management.
Oh.
That's the best part about working with teenagers, is that I can reserve my role as being someone who can join with them and help work on motivational interviewing and be kind of not another adult that's just going to lecture them and tell them what they need to do. But the parent can, or the guardian or the adult in their life can act as the agent of contingency management. And what that means is essentially, if they don't have internal motivation for change, you can help provide external motivation for change. And and people, like in the past, I think there was this idea that the person has to want to change, or they have to have internal motivation for anything to be different. And until they have internal motivation, then everything's just going to be the same. And so there was this almost like passive, and I actually have some parents that will still say this sort of like passive approach where it's like, well, they're just going to do their thing and then hopefully they eventually realize.
Yeah.
Right. But if you think about an adult, right, there are external motivations or external factors that motivate people to make behavior change all the time, right? Like you get, pulled over and arrested for driving under the influence, right? You're on probation. One of, health professionals that have struggles with substance use, there's what's called a health professional monitoring program. And the outcomes of those programs are amazing. Most health professionals that are enrolled in a health professional monitoring program end up having a resolution of their substance use disorder and go on to lead great lives. And part of the reason for that is because there's a lot of external motivation, right?
Yeah.
You don't want to lose your livelihood, your medical license. You're getting regularly drug tested or tested for alcohol. So you sort of have this, you're compelled. And so, yes, the teen that shows up that's like, I'm not doing anything different. This is like my everyday. I have tons of, teen boys that show up that are like, I'm going to be a marijuana grower and move to Washington, and people just don't get it. And, it's just treating my anxiety, which I'm not even sure they actually have anxiety, or if it's just their reason why they like marijuana. That's what they tell people. Yeah. And so I will meet with parents individually and I'll say, look, your child doesn't have any internal motivation for change right now. They don't think that there's anything negative happening as a result of the choices they're making. So the two things that you can do as parents is allow natural consequences and give them some external motivation. And so I have this case that I just love for this because I wasn't sure how it was going to turn out in the end. And I may have told you about this case before, but she was a high schooler who was smoking marijuana and using nicotine, didn't think there was any problem with it. There were objective signs that there was a problem with it. She had a use disorder. Her parents made her go to an intensive outpatient program. She's a very cooperative kiddo, so she did it. She was fine. She stayed away from substances during the program. She started to recognize once she had been away from the marijuana that was kind of dumb that she was doing it so much. And she was able to recognize that it negatively impacted her relationship with her parents because they didn't want her to do it. But beyond that, she was still kind of ambivalent. Went back to school. She said it was available everywhere at school. Like it was in the bathrooms, like the vapes with marijuana. Her friends that she still had from her school were doing it. They're like, what do you mean you're not going to do it anymore? But parents were really adamant that no, this is not acceptable. You're not going to be doing this. And so they drug tested her every week.
Oh my gosh.
And they said, if you come up positive, then you're not using the car for the weekend. No. So I'm sorry if you have a work shift, but you're going to have to call and cancel your work shift. We're not driving you. You're going to be at home for the weekend. And she was so mad. She was like, there was a good section of time there where she was like, my biggest problem is my mom. I hate her. This is awful, right? And mom was like, I would meet with mom and she was like terrified that this was the new relationship with her kid. She's like, I don't. And the beautiful thing about it was that the anger and the frustration faded as mom held consistent. And it wasn't an emotional thing. It wasn't like there weren't fights about it. It was just like, well, you know what the deal is. So, putting the car keys away for the weekend. And eventually the kiddo had more external motivation, which helped her move through her ambivalence. And the longer she was free from marijuana, the more she started to hang out with kids that weren't smoking because it's like boring to hang out with people who are getting high when you're not getting high, right? So she started to hang out with other people. The more she's like, how dumb I was, like that's not who I am or who I want to be. And so she was able to she's still free from marijuana, is actually at college now and isn't using, and is doing beautifully and has all of the internal motivation in the world, even though she didn't start out that way.
Yeah.
And so that's kind of a story I like to tell because it's a way that a parent can really step up and do something hard that is for the health of their child.
Yeah.
Almost like you don't like to hold your kid down when they get a vaccine. I know vaccines can be controversial, but you don't want to do that, but you do it because you're like, I know that this is in my child's best interest. Or you push them into their car seat and you buckle them in, even though it breaks your heart.
Life.
Yes, it breaks your heart because they're so upset. And if it was reasonable to just let them not wear a car seat, sometimes your brain would be like, maybe we could just do that. But it's like, no, this is a health issue. It's a safety issue.
Right.
So the goal would be to get parents to think about marijuana in teens as a health and safety issue and then do what's hard. That was, again, I give you long answers, but.
That was such a good example. Okay. As we're thinking about kind of the role of medication as a psychiatrist, I mean, I know there's medicated assisted treatment. I mean, but I would imagine that those are for like way more severe cases where like opioids, would you use MAT for something else besides opioids?
Yeah, good question. I love talking about MAT and medications for substance use disorders. Another area where like you don't get training in medical school or even in psychiatry residency. I picked programs that gave me training, but a lot of people don't get training.
Well, do you think that's because there's so much stigma? Is there still stigma against medicated assisted treatment?
Yeah, there's still stigma against it. It's better. I think having so many people die from opioid overdoses has really helped to push people to be like, it would be cruel to not give people with opioid dependence medication to keep them from dying. Like that would just be cruel, right? So that part's, I think, gotten a little better. But so medication-assisted treatment is really for any type of use disorder. So we have medications that have some evidence for marijuana use, alcohol use, methamphetamine, cocaine use, and then opioid use.
I did not know that.
Yeah, and some of them are used in a harm reduction fashion, which what that means is that the individual doesn't have to say that they want to be done using, but we can prescribe the medication to try to decrease the risk of harm from their use. And so, a example of this would be, a classic example would be naloxone, which is Narcan, right, is considered a medication for treatment of addiction because it prevents overdose death. The individual doesn't have to say they want to stop using opioids, but we still prescribe that in order to minimize the risk of harm to them while they continue to use. Another one in adolescents that's kind of cool is N-acetylcysteine, which is a over-the-counter supplement. So it can just be purchased like on Amazon. It comes in all kinds of different gummies or whatever. And there's evidence that regulates something called glutamate in our brains, and that by regulating glutamate, it decreases cravings for substances.
Interesting.
Yeah.
What?
And so, so I use that quite a bit in adolescents that are sort of, pre-contemplative or contemplative about their use of marijuana. If they're willing to. It's kind of a pain because you have to do it twice a day, but you can get it as just like a chewy gummy. So it's, easy enough. But and the research has shown that it helps people. So when they did a study where they had people do like a placebo and then they weren't interested in making changes to their marijuana, but they just tracked the marijuana and then they gave it to people. They gave them the active N-acetylcysteine and then had them track. Those that had the N-acetylcysteine had decreased use, even though they weren't trying to do that necessarily.
Wow.
They had less likely to have a positive urine drug screen. And then they also noted that they had less euphoric effect or positive effect from the marijuana, which is interesting because I have had some kids that will stop taking it because they're like, when I take it, my high doesn't feel as good.
Yeah, I bet not.
So I'm not going to do it. So sometimes it doesn't work as well. It has to maybe be in somebody that wants to try to cut down. But and similarly, naltrexone, which is different than naloxone. Naloxone is Narcan. Naltrexone is similar but different, and we use that one a lot for different things. But one of which is alcohol use, and that one has done something similar or does something similar for people that drink. Is it helps them decrease drinking days, decrease the amount of alcohol in a sitting, and decrease the pleasurable feeling from alcohol. So it just is kind of a good harm reduction medication.
Oh, fascinating. Oh man, what about would you use? Like, I'm just thinking through. I feel like for alcohol use disorder, I remember working with a family who the dad would take something And then if he had alcohol, it would make him throw up. So like it would make him so sick. What is that medication? Is that still used?
So it is sometimes. So disulfiram is the generic name and Antabuse is the brand name. Yeah.
Stop.
And it was, so it's an old medication. It was invented during a time when, again, the idea was that you had personal problems and so you would drink. So this was going to like punish you if you drank. So it fell out of favor. As it should have if that was how it was being used. But I do use it sometimes now, but it's always a patient-driven decision. And so like the classic story is, right, like you're trying to not drink, you've already moved into the phase of knowing that it's a problem, but you get extreme cravings and it's really hard in the moment to use a coping skill to deal with cravings. I've had some patients that are addicted explain it like trying to hold your breath. That at a certain point, it feels like you just have to breathe or you're going to die.
Oh, wow.
They'll explain that alcohol does that to them, where they feel like when they try to tolerate a craving, it feels like they're trying to tell themselves not to breathe, that it's painful and it hurts. And so this, again, if a patient wants this, would be another layer of motivation to tolerate the distress that it is to have the cravings and not use, because you know the consequences of drinking are so severe. And typically it works better if it's kind of like combined with another kind of healthy adult in your life, because what will happen is you just will choose not to take the medication. Right. And so often it can be part of like a dyad. So, let's say it's like a young adult that does really want to take the medicine because they don't want to drink. They're committed to not drinking, but it gets really hard. And then they live at home and then their parent dispenses the medication to them in the morning as just kind of another layer to prevent them from drinking.
Yep. Oh, fascinating. Other medications or other things that to keep in mind around substance use disorder?
Yeah. So to just touch quick on Suboxone.
Oh, yeah.
So Suboxone is the brand name. Subutex is another brand name of the medication, which is called buprenorphine. So buprenorphine is a really evidence-based medication for opioid use disorder. There's also a medication called Methadone, which I think some people get confused between those two. So Methadone is, so the way that I kind of think about them is something like fentanyl or like Percocet or oxycodone goes into your brain and it gives stimulation to the opioid receptor, which then floods your brain with dopamine. And that's part of that is what makes it feel good for some people and creates an addiction. Methadone is similar in that it goes into your brain and it gives stimulation to the receptor, the opioid receptor, but it doesn't give you really high levels of stimulation. It kind of gives you this like baseline stimulation. And so that's a really effective treatment for opioid use disorder, but it can come with side effects like sedation. If you took more than you were supposed to, you could get euphoric or high from it. So it's a very controlled treatment. So people that want methadone need to go to methadone treatment programs, which since the pandemic, they've been a lot more patient-centered, meaning you don't have to show up every morning at 6 a.m. to get your dose, which is kind of how they used to be. You can earn your way to what's called take-homes, where you can get like a week and have it at home, but you're required to participate in groups and submit to urine drug screens when you're asked to. So that's methadone. And then Suboxone or buprenorphine is a medication that goes into your brain. It gives the opioid receptor a little bit of stimulation, but it also blocks it. And so it works really, really well for opioid use disorder because it helps prevent the cravings and the withdrawal and kind of the negative feelings and physiologic body reaction that come from opioid dependence when you're trying not to use. But it also gives you the protection of blocking that receptor so that if you did use an illicit opioid like fentanyl or you took a oxycodone, you wouldn't get a euphoric high from it. It would just sort of, your body would just like pee it out. So, and it's not as rigid or structured as methadone is, meaning that it can be prescribed in a doctor's office. And so I prescribe a lot of Suboxone. It's actually a very safe medication. It has what's called a ceiling effect, meaning that you can't really overdose on it. There are case reports of people combining it with other things, but it's never been clear. Like I think Matthew Perry, right? So that there was some question when it came out in the news. I think those of us that are in addiction were like tuned in on like, what did he overdose from? Because the news reported, well, he had Suboxone in his system. And so then I was worried that people would jump to the conclusion Suboxone's bad and causes overdoses. But thankfully, I think the news did an okay job of then clarifying that they thought it was a different substance, that it wasn't the Suboxone. So this just as an example, it's usually not the Suboxone that's causing the risk. It's another substance the person uses. But the medication is still kind of stigmatized. I think it's better than it used to be. But, and it used to be that as a doctor, you had to have a special waiver to prescribe it, which they've done away with that because they've realized the medication is a lot safer than a lot of the other medications we prescribe. Like docs prescribe oxycodones and Percocets without any kind of waiver. And here we are with like a medication that's actually safer. And you had to do all this extra training and it created, and again, it came from stigma.
Wow.
I think.
Oh, wow.
Yeah. But anyway, so that's another medication where, and a question I get about it that a clinician might get is like, I don't want to go on it because either I don't want to trade one addiction for another addiction, or I don't want to have to be dependent on it and be on it the rest of my life. And so that first question, the way I typically respond is like, you have an illness and the exposure to the medication has changed your brain. And so to expect you to go from using to nothing is cruel. It would be like telling a diabetic that they are supposed to just go without insulin because you've actually had biologic changes to your brain that require treatment, which is what Suboxone or buprenorphine is doing for you. So that's kind of how I approach the like trading one addiction for the other. And then I've had a lot of people taper off of Suboxone or buprenorphine and do just fine. So this idea, there's like you'll see on Reddit or, in communities, they'll say like, well, once you get on it, you're never getting off of it. And that's not true. I've had a lot of people get off of it. I think partly what might happen is that some people have like damaged their brains so much with opioid dependence to the point that their brain's never going to be able to heal. And then it might be those individuals that have that experience where when they try to go off of the medication, they suffer. And again, it'd be like, yeah, your brain, I'm sorry, but you've damaged, your brain is damaged. And now you need this in order to, be able to have a good life. And there's nothing wrong with that, just like other people that have illnesses. But that isn't the case for most people. That would be like a smaller group.
This has been such a good conversation. I feel like I've learned so much from you.
Good.
Thank you so much for joining and chatting through all of these different things around addiction and substance use disorder. Stay tuned because our next week's episode is going to be on motivational interviewing and kind of like where to go from there. But also you can use motivational interviewing, with your spouse and kids and everyone. So
everyone, coworkers.
Yes, exactly. So thank you so much for joining.